Hi, good afternoon. So my name is Ivan Flores. I'm a pediatrician by training. I have been involved in the guidelines research for more than a decade. And currently I'm full professor at the university that you can see here in Colombia, but also part-time professor at McMaster University, where I did my PhD. I'm also have a couple of additional positions there that I'm not going to read, so you don't get bored. I'm also the editor-in-chief of a new journal only dedicated to the guidelines enterprise. So today, I'm going to talk to you about what is a credible guideline, which is a key distinction that we need to do in guidelines, also as for us, as methodologists and people who are going to use guidelines, regardless of the topic of the guideline. My conflict of interest is more about what I just mentioned, my position. I'm also hired by the Guideline International Network because of the journal that I'm leading right now. All the funding that I have of my projects are related to the Canadian Institute for Health Research or the Colombian Ministry of Science. Do not be misled. I want to start with this sentence. Not everything that is called as CPG, which is clinical practice guideline, or an evidence-based guideline, is a real guideline. And I'm going to tell you a little bit about that. This is the definition of what a real clinical practice guideline, according to the Institute of Medicine, now National Academy of Medicine. Guidelines are statements that include recommendations intended to optimize patient care. They are informed by a systematic review of evidence and assessment of benefit and harms of alternative care options, which means, as you can see, is highlighted there. The guidelines need to be based on systematic reviews. And you also need to balance what are the benefits and harms of the potential intervention that we are dealing with. So just to mention that this is kind of the most accepted, globally, the most accepted definition of what a guideline is. For that purpose, the IOM, now National Academy of Medicine, established a set of standards of what should a guideline have in order to be considered a clinical practice guideline. There are 8 standards that you can see there. I'm not going to read all of them because there are other standards that I'm going to mention. It is important that guidelines are transparent, conflict of interest management. There is a real multidisciplinary guidelines group composition. The guidelines should be based on a systematic review, as I just mentioned, establish the evidence foundation for rating and the strength of the recommendation, and also how the recommendations are articulated with the processes in the context they are going to be implemented. There should be an external review and there should be an updating. This is what the IOM says and it's still current. But we also have the Guideline International Network standards, which were published in 1 year after the IOM standards. And I am not going to read all of them, but you have composition of guidelines, decision-making process, COI, methods, evidence, guideline recommendation, how we rate the evidence and the recommendation, the external review, financial support should be transparent, and the conflict of interest, and also the update. So as you can see, the standards more or less cover the same points, and it's important that either them or this standard should be met. But we also have some tools like the one that was published by Romina Brignardello, who will be with you tomorrow, and Gordon Gayat and Alonso Carrasco in JAMA 2 years ago, which is a set of questions that we should follow when we, as users, mostly clinicians, are interested in identifying a credible guideline. And there is a set of 5 questions that have sub-questions that I am not going to read, but in general, they are more or less on the same. Recommendations should be clear and actionable. There should be an evidence summary. The guidelines should consider all the outcomes that are important, and judgments should be considered, values and preference, and the recommendation applied to a specific patient. So this follows the usual process that we do when we are teaching people to assess, to critically appraise the literature. So it's not only applicable, this standard to guideline, but also to other type of research studies. So as you can see, there are several ways to see that we can understand, see if a guideline can be of quality. Then there is, okay, in summary, what are the standards of a high quality clinical practice guideline? And I'm going to summarize what these standards say. First, transparent funding and support. It should be clear where the money comes from to the guideline and should be explicit. Also, not only that, but also the organization that is funding the guideline should not have any impact on the final recommendation. So the developer should be independent of the funder. Multidisciplinary, balanced, and representative composition of the group. That means that all the potential stakeholders and participants, professional and patient, of course, and in case of children, parents or caregivers should be represented in the table of people who are doing the recommendations. It should be balanced, it should be a good representation. It also always, of course, depends on the topic. Depending on the topic, we will need to choose what are the best people who need to be set there. Consideration of patient values and preferences. Guidelines groups needs to ask patients what they prefer, but also search for literature about patients' preferences. It's not only about asking one or two patients what they think, but also doing systematic review. We are suggesting that developers do systematic reviews of studies that have addressed the values and preferences for the specific condition we are interested. Fourth, disclosure and handling of conflict of interest. As you can see, disclosure and handling is not only disclosure. Many guidelines just disclose it. As you can see, at the bottom of the guideline, before the references, we disclose that A, B, and C have been receiving some funding from whatever pharmaceutical company, and the other guy also from the other pharmaceutical company, and that's it. And they don't do anything about it. We need that the guideline groups state what they did with that, because there are financial, and in this case, for gender dysphoria, we have seen also important intellectual conflict of interest that need to be handled. And when I mean handled, is that some of these conflicts make some members of the group not good members, which means if my conflict of interest are very strong, very deep, some people may need to be out of that group or out of a specific recommendation. Sometimes people are part of the group and they only have conflict with a specific question or with a specific treatment or for a specific intervention. They can get out of that specific question and they could continue to be part of the full group. That needs to be stated in the guideline, and we expect that the guidelines provide all the information, what they did with these specific conflicts. The development of pre-established scope and question of interest. That means that the groups need to agree on what are the questions they're going to cover in the guideline process. It's not something that we just sat and we came with the recommendation. The questions should be agreed in advance before we go to the systematic reviews. That'd be very clear. And there is an international initiative in which we are trying to encourage guideline developers to register the guidelines and to put all the information available before the guideline is out, very similar to what happened with clinical trials. That we have registration before the trial is done. That's an international initiative that we are trying to encourage people to do. So that's something that we are just changing, and with that, we are not having enough guidelines right now registered, but we will have in the future. 6, systematic and transparent, which means, 1, the search of the evidence, which means all the process, the systematic review process, where to search, what databases were searched, and how the selection process, the eligibility criteria was considered before, and what is the methodology for the assessment of the quality or the certainty of the evidence. We would expect that people use very accepted processes to assess the quality of the evidence. We encourage people to use the most accepted system, which is the GRADE system. Unfortunately, not all the guidelines are using GRADE, but that is using GRADE, we will meet for sure this criterion. The process for moving from evidence to recommendation, which is the last bullet point here, very key process because we are not going to provide recommendation only based on evidence. We need to consider additional factors, as we were discussing very recently. That evidence is one key factor, but we also need to consider cost, values and preference, feasibility, applicability, among other things. And finally, the CPGs should have very clear recommendation, actionable, very clear, that people read the recommendation and know what to do, have tools to enhance their implementability, which means there are specific tools that helps to put in practice the recommendation, like, for instance, flow charts, algorithms that help in the process of implementing the recommendation, have considered cost. Many guidelines don't consider cost at all. And it's important that they also consider what is the impact that it's going to have in a specific healthcare system. Equity issues, when we are doing a recommendation, is this going to be a recommendation that will increase inequity in health, or it's going to reduce inequity because some recommendation will be accessible to some specific people who have more funding, are more affordable, and people who are low income, for instance, will not have access, and that will create an inequity. We need to consider that. Have been reviewed before publication by peer, which is the external review, and finally, that a clear updating process, which means the group should be very explicit in when do they think that the guideline should be updated and how should be updated. So too many criteria, no? Too many criteria. So as you can see, as you go back, how many of the guidelines do you have read before meet all these criteria? I don't know. So to meet all these criteria, guidelines end up being expensive and time-consuming, require a significant amount of expertise and training. That's why most of the guidelines are low quality, because there is no specific, a lot of expertise everywhere. And not all the people who know how to do this are able to participate in these guidelines. And many people consider that consensus is similar to guidelines. Consensus is just a group of people sat around the table saying what to do without a systematic review of the literature. So that's why it's difficult to have a high quality guideline. So developers, people who develop guidelines, many do not have this expertise, and or they don't have the capacity or the funding to develop this. Many groups, they know, they are aware that they don't have this capacity, and they commission to external groups to do the systematic review, and that's fine, as long as they follow the whole process, the good process. So what about the users? People like you and many other people who are just reading guidelines. So usually, most of the people don't have the expertise to differentiate a high from a low quality guideline. Commonly, users rely on the prestige of the developers. If that is developer group, we trust them. And that's a problem, because many societies are not doing a good job with guidelines. So not so good guidelines may lead users to recommend ineffective treatments. Treatment with no value for money, and therefore will lead to an increase in healthcare expenditure. Treatments that are not implementable, that will create gaps in healthcare and inequalities. And treatment that are not acceptable by patients, or that could lead to lack of adherence or abandon of treatment. And this happens when we just recommend whatever guideline, because a low quality guideline may not consider this. That's why we need to be very careful. That's why AGREE exists. AGREE is a collaboration of international researchers aimed to create tools and resources that support guideline enterprise. The idea is to optimize the quality of guideline, minimize bias, and ensure usability. AGREE 2 was the first version, was published in 2003, and it was updated in 2010, and we are planning to do an AGREE third version. But still we're in the process of designing the process. But the idea is that these tools are useful for evaluation of the quality of guideline and to serve as a blueprint for the development and reporting. All the AGREE tools go through this process, complicated process, to create a new valid tool that should be that follows steps to generate the items, to item reduction, scaling, clustering, a process of reliability and validity. And all this process is also about usability. We need that users think that the tools are usable. All the AGREE tools have followed this path, and so they have been developed following the best standard for validation of tools, to validate the tools. So that's why AGREE 2 is the only validated tool to assess the quality of clinical practice guidelines, and is the most used globally. The AGREE 2 instrument, of course, we don't have enough time to go through all of the steps, but AGREE 2 instrument has 6 domains, and the 6 domains are covering 23 items. The first domain is a scope and purpose, that in summary means that the guidelines should be very clear about the objective, should be very clear about the question that they consider, and the population of interest. Stakeholder involvement, as I mentioned before, is about having a multidisciplinary team of all the individuals from the relevant professionals, professional groups. The views and preferences of the patient are considered, and the target user of the guideline are clearly defined. The rigor of development is the third domain, and is considered globally the most important domain, because it goes through 8 items that cover all the steps of a good systematic review, which is about the systematic search, the criteria for including, the literature, the strength and limitation of the body of evidence, and the method for formulating recommendation, and the consideration also of side effects. And there is an explicit link between recommendation and the supporting evidence, and also the external review and the updating process that I mentioned before. And clarity of presentation is about how clear are the recommendations, which means that the recommendations are specific and ambiguous, the different options for management of condition are presented, and key recommendations are easily identifiable. And applicability is about the implementation. How applicable are going to be the recommendations? The guideline should consider facilitators and barriers. The guideline provides an advice on tools like flowcharts, as I mentioned before, and the potential resource implication, which means considering cost, are also part of the guideline process. And the guideline presents monitoring and auditing criteria, which means creating indicators to monitor the adherence. And very importantly, editorial independence, which is first, where is the funding coming from? And it's explicit in the guideline, and also that the competing interests, as I mentioned before, have been declared and have been addressed. So these are the 23 items, and each one of the domains, just to mention that AGREE has other tools. This is just to, you can know a little bit about AGREE, but there are other tools that cover additional aspects of guidelines, just to mention. For instance, we have AGREE Surgery, which is AGREE only to evaluate guidelines on surgery. The AGREE tool has a manual that has a step-by-step explanation of all the items that I just mentioned. Each item is defined, example of each one of these items. It has been translated to 20 languages, so it's used globally, as I mentioned. We have a website in which you can go and have more information, agreetrust.org, and you can freely download the translation and the tools and all the resources. And we also have AGREE Plus. There is a website in which you can do online the quality assessment and get an official report. And the scores is what we obtain. We obtain a score from 0 to 100% per domain, because there are 6 domains. We're going to obtain 0 to 100% in each one of these domains. There is not a specific magic threshold to say that the guideline is of high quality, and that's one of the critiques, more common critiques to the tool. The most used threshold is 60 and 70%. So if I get more than 60 or more than 70% on a specific domain of the 6 domains that I mentioned, that means that the guideline is covering really well that specific domain. The most important domain usually is rigor of development, as I mentioned, domain number 3, which is about how systematic the review, the evidence process was. This is an example of 4 guidelines. This is a very didactic example in which we have 4 guidelines that had different scores for each one of the 6 domains that I just mentioned. As you can see, there are many numbers here. But I just wanted to mention, if we choose that 60% is going to be our threshold to define high quality, now you can see that, for instance, rigor of development, the guideline number 1 got 65%. If I chose 60%, that means that the guideline is of high quality, and the guideline number 4 will be of very low quality because it's below 60%. Some organizations and some researchers don't use 60%. They use 70% as a threshold for quality. And as you can see, when we choose rigor of development as the most important domain, the guideline number 1 under this threshold is not a high quality guideline anymore. It's only, we will say that guideline number 2 and guideline number 3 are getting a scores of more than 60 in rigor of development. They could be considered high quality guidelines. But as you can see, editorial independence is really good score for guideline number 2, but not so good for guideline number 3, which means that this guideline didn't do a good job with conflict of interest management, and the funding process was not transparent. So in this case, if the 4 guidelines are more or less the same, we may be more confident if we use clinical practice guideline tool for our decision. So that's how we work. People who are trained in AGREE could be able to assess the guidelines. We need to have at least 2 assessors, get the scores, and these type of AGREE scores can help us to take the final decision on what guideline I should trust the most. So that's what I have it for you during this conference. If I have any question, happy to answer later. Sorry.